informed a lot of presenters. Some of the presenters haven't uploaded their PowerPoint files. For those who haven't done so, you may ask the tech team at the back. So in the interest of time, we may need to start, but I'm not sure if the presenters are here. Is Dr. Yanshi around? Okay. How about Dr. Yin Hang Zhang? None, okay. Dr. Amrita Day? Okay. Dr. Preeti Kumari? Dr. Nadir Nasiri? None. Dr. Feng Zhang? Okay. Dr. Jan Jiaswan Zhang? Okay. Dr. Mahar Khan? None yet. Dr. Shiksha Gupta? Okay. Dr. Gang Wei Cheng? Oh my God. I think it's a lunch. I wishful thinking that some of them would be here already. Dr. Ping Ge? None yet. Okay. Too bad. There's a lot of interesting presentations. Maybe we'll give them around 5 minutes. I was actually looking forward to it, but I presume some of them might not be able to come due to some other travel issues. Okay, so we'll give 5 more minutes, I guess. Good morning. Good afternoon. We'll rearrange the presentations based on the availability. We have for our first presentation, Dr. Preeti Kumari will present state of mental health among glaucoma patients, an issue that needs to be addressed beyond routine glaucoma care.
Yes.
Sounds interesting.
Good afternoon, everybody. I am Preeti Dubey here. I am talking on the state of mental health among glaucoma patients. Starting with the introduction, glaucoma is a progressive degeneration of the optic nerve head resulting in visual field defects. It is the leading cause of irreversible blindness globally, and it is often referred as silent thief of sight. The psychological impact of chronic vision-threatening disease is often overlooked in regular eye care. Coming on to the current situation, in India alone, there is 12 million people who have glaucoma, and we have found 3 main problems. First is a healthcare gap, that is, the eye care focused solely on the physical symptoms. The second is there is bidirectional relationship, that is, the mental health and glaucoma affect each other, vice versa. And the third problem was care fragmentation, that is, the eye care facility and the mental health services remain disconnected. We did this study for following reasons. We found a profound impact of glaucoma on both the physical and psychological well-being. Anxiety and depression are common comorbidities in every chronic disease, and there is limited research over this topic in India especially. And we need to understand the contributing factors to tailor the interventions. Coming on to the aims and objectives. The aim is to determine the association between glaucoma and depression anxiety disorders. The objectives are, first is to determine the relationship between the depression anxiety with severity and duration of glaucoma. The second being the association between the depression anxiety disorders and compliance to glaucoma treatment. Next, the methodology. This hospital-based cross-sectional observational study was conducted in Department of Ophthalmology in SNMC Agra. Total 180 patients were studied between duration of November 2022 to April 2024. Ethical approval was obtained. The criteria: we included all the glaucoma patients over 18 years of age. Exclusion criteria were glaucoma with any other chronic eye disease or the patients already on psychotropic medications or pre-existing mental health diagnosis were excluded. Patient with substance abuse or whosoever declined participation were excluded. Assessment. Complete ocular examination was done. For psychiatric assessment, we used Hamilton Depression Rating Scale and Hamilton Anxiety Rating Scale, that is HAM-D and HAM-A. Coming on to the results. Demographics. Of our patients, 60% were males and remaining 40% were females. Most were between in the age group of 40 to 59 years. Prevalence of depression and anxiety. We found depression was diagnosed in 17% of the patients, where 13% show the mild symptoms of depression and 3% show the moderate symptoms of depression. Anxiety was diagnosed in about 7% of the patients in our study, which was evenly split between mild and moderate symptoms. Coming on to the gender-based distribution, depression was more common among the female glaucoma patients, while anxiety was more prevalent among the male glaucoma patients. Coming on to the glaucoma severity and psychological disorders, we found a strong connection between the glaucoma severity and the mental health issues. As we can see, the half of all the patients with the end-stage glaucoma had depression. Similarly, anxiety was much common in patients with the advanced glaucoma. Coming on to the clinical characteristics and the psychological disorders, we found the patients with depression or anxiety had worse indicators of glaucoma severity. Both were associated with significantly higher CDR, lower VFI. Both conditions were associated with more medication use. Surprisingly, the duration of glaucoma was not significantly different in either condition. Treatment compliance and psychological disorder. 60% of the glaucoma patients with depression were not taking their medications properly, compared to only 26% without depression. Surprisingly, the anxiety didn't seem to affect the compliance, as 75% of the anxious patients still took their medications properly. Key findings of my study is prevalence. As earlier discussed, 16.6% showed depression symptoms and 6.6% showed anxiety symptoms. Disease severity, significant association between the severity of glaucoma and depression and anxiety were found. 50% with end stage had depression, 29% of the patient with end stage had anxiety. Coming on to duration of disease, there was no significant association between duration of glaucoma and depression anxiety. Treatment compliance, depression associated with poorer treatment compliance, while anxiety did not significantly impact the compliance. The clinical implications of the study are holistic approach. We should target the high risk groups and we should improve the compliance, which may improve the quality of life of these patients. The recommendations are regular screening for depression, multidisciplinary care, that is collaboration between psychiatrist and the ophthalmologist is needed. Patients should be educated and further research to establish a causal relationship has to be done. Thank you for listening. Have a nice day. Thank you, sir.
Great presentation. There's actually a scarcity of in the literature regarding depression.
Yes, sir.
It's quite interesting that those who have depressed it's a risk factor for non-compliance.
Yes, sir.
So how do you plan in terms of addressing that? For those with advanced glaucoma, would you suggest to have screening for depression and anxiety?
Yes, sir. So whenever these patients approach in the OPD, we can see that they are very apprehensive and they are always complaining of their insomnia, they have lack of sleep, or they have some genitourinary or some gastrointestinal symptoms also, which refer, or they don't have this feeling of pleasure in doing the things which they earlier used to. So we get it counseled from the psychiatrist. They apply this HAM-D and HAM-A to just diagnose the severity of the depression or anxiety which is present, and then they counsel and give the required medication, sir. And we have seen that whichever patients we have referred to the psychiatrist, we have found the compliance has improved in these patients after proper counseling of these patients.
Yeah, that's great. It's a holistic approach.
Yes, sir.
Did you take out some other comorbidities that could add to the depression aside from ocular comorbidities?
Yes, sir. Diabetes has itself been, because in India it is not like, sir, not everybody is so blessed financially. So the chronic diseases are very hard on the pocket, sir. it seems like it is very easy to get these medications, but on a long run, it costs hefty on the patient. So any chronic disease, be it diabetes or simply hypertension, they cost very much to the patient, so they'll end up in depression.
Okay, so but you didn't take it wasn't an exclusion criteria.
No,
in
sir,
this
it
study.
was.
It was. It
Yes,
was.
sir, yes.
Okay, so you took
Yes.
the path. Okay, thank you very much.
Thank you so
Uh,
much, sir. Thank you,
Great
sir.
study. I hope you continue on. What's the question, sir?
Would it not be great to operate at least one eye of such patients?
Yes, sir. We should always consider them. Yes, sir. But yes, sir. As I discussed, that most of the symptoms of psychological disorders were found in end-stage glaucoma. So as there it is like uh, snuff out phenomenon. So, sir, we like kind of prevent those eyesight which is there already.
So you can always operate one eye.
Yes, sir.
Yes, that's a very good point, sir.
Yes, sir.
But make sure that the depression is also
Yes, sir.
addressed, or else they won't use the post-operative medications,
Yes,
and
sir.
it's
Yes.
vicious cycle.
Yes.
Okay,
Thank you
great.
so much, sir. Thank you for listening.
Excellent. Okay. I know. Yeah.
So good afternoon, everyone. I'll be talking about, it was a randomized controlled trial between circumferential versus hemigunoscopy-assisted transluminal trabeculotomy in primary congenital glaucoma. So far, the conventional treatment of choice for primary congenital glaucoma has been combined trabeculotomy with trabeculectomy. Angle surgeries lately, it's moving on its own. The slides are moving. Can you just exit and stop timings?
Yeah.
Sorry. So the angle surgeries including GAT have shown promising results in PCG and GAG so far. So this study was basically, there was a confusion in how much to excise. Is it safe to excise 360 degrees of the trabecular meshwork in these young eyes? Does it hamper the trabecular pump function in these patients? And that is why there was no answer to this question, even in adult or primary glaucoma at that time when we conducted the study. And hence the study was envisaged. So the aims and objectives of the study was to determine the safety as well as the efficacy profile of GAT in primary congenital glaucoma, and then to compare the surgical efficacy of 360-degree excision versus 180-degree excision in PCG. So it was a prospective randomized study which was enrolled and ethical clearance was obtained. The PCG children with mild to moderate grade with corneal diameters less than 14 millimeters and relatively clear corneas were recruited. It was randomized using a random number table generated, and examination under anesthesia for all the baseline parameters was done, followed by surgery was conducted. So the inclusion criteria I have listed, and the exclusion criteria were anterior segment dysgenesis, syndromic associations, or any other cause of glaucoma. So there were two success criteria. One was the target IOP of 18 millimeter mercury, and the second one was 15 millimeter mercury. And the success was calculated based on both the criteria. And need for systemic acetazolamide or resurgery or IOP hypotony with less than 6 millimeter mercury or loss of perception of light was considered as failure. So in the results, we can see that this rhomboid is the 360-degree GAT, and 180-degree GAT is the circular forms. And we can see that post-operatively, this is the criterion A and this is the criterion B. This is the pre-operative IOP in the horizontal axis, and this is the IOP at 1 year of follow-up. The patients were followed for at least 1 year. And we can see that the rhomboids, they fall more in the lower IOP range in the post-operative period, whereas the hemi-GATs or the 180-degree GATs, they had some shoot in the higher range even after the surgery. So though both the groups demonstrated significant IOP reduction at 12 months, however, whether the cumulative qualified success rate as well as absolute success rate was significantly better for the 360-degree group in these children. So we can see these Kaplan-Meier graphs for 24 months, and we can see that the qualified success as well as the absolute success for both the criteria, they were better in the 360-degree group. Additionally, at the end of 12 months, 4 eyes in the 360-degree group required medications, and the IOP got controlled, and therefore the hypothesis that the medications may not work in the eyes where we have removed the trabecular meshwork circumferentially did not hold true, and they responded well to the medications. So 1 in 5 of every eye which underwent Hemigat exhibited increase in IOP. Another important finding was that there was a reversal of cup disc ratio in the eyes which received 360-degree treatment, which was significantly more in this group compared to the 180-degree group. So this is the baseline CDR, and the y-axis shows the CDR at 1 year. And we can see at post-operative period, the CDR was better, and it reversed actually. This is one of the patients which demonstrated reversal after surgery. So this is also an indication that maybe circumferential should be preferred in these eyes. Other than transient microhyphema, which never needed drainage, there was no other complication, but one eye of 360-degree GAT did experience 1 clock hour of iridodialysis, which was not harmful to the patient. So we can conclude that circumferential GAT is superior to Hemi-GAT in PCG and offers better IOP lowering, lesser need for medications, and also better CDR reversal, and it can be considered the initial surgical procedure for PCG, particularly for non-severe ones with a better safety profile than CTT. The limitations of the study was a small sample size and short duration of follow-up, and the patients included PCG with a relatively clear cornea. Thank you very much for patient listening.
Excellent study.
Thank you.
What would be the difference because there's some who would other studies also would be saying that 180 is just as good as 360.
Yes.
What do you think?
So that those studies have been conducted not in children but in adults. So all of these studies, this is the first study, and we've been able to publish it accidentally after the submission. So in adults, they say that for primary glaucomas, 180-degree could be as good as 360-degree with no harm of doing 360 degrees, and we also don't recommend doing circumferential treatment in primary adult glaucomas. But in children, we feel that since it is the procedure which is being done under GA, and it's the first chance that we are giving to the baby, that it should, it should leave him good IOP control for the lifetime. So we think we wanted to know whether we should do what procedure should be the best for the best IOP lowering at the first stage. And we did find differences in a short follow-up of 12 months also. So now we have the second part of the study. It has become the first-line treatment in our center, so the paradigm has changed, and we're no longer doing nasal goniotomy or CTT as the first-line procedure. But in adults, no, we're not doing 360-degree treatment.
Okay, great. Any questions from the audience? So it's really good that you have this evidence already in terms of shifting your treatment.
Yes.
I would encourage you to go on, continue following up these patients for the long-term outcomes.
Thank you so much, sir.
Thank you very much. Any of the presenters here still? Oh, wow. Okay, 2 out of 3. There's still tomorrow. They might be in Taj, I think.
Step by step to do 360-degree GAT in children. So initially, and we did encounter some difficulties when compared to adults. These eyes are, non-pigmented. Plus, they are buophthalmic, stretched, and most of the times the angle is featureless. You don't even get to know where to incise. So then we innovated multiple techniques which are also published now. So one is the ipsilateral compression of the external jugular vein. When we do that in a child, with the help of the anesthetist, of course, so it causes reflux of the blood in the Schlemm's canal, and it is a very easy method, and 100% we are able to cleave at the right position and suture it circumferentially. The other was we are doing a lot of ICG angiographies, which is aqueous angiography, which is the flex module of the Heidelberg spectralis machine, which is done in the OT. So for that, we have to inject ICG dye in children. So we have published some papers on aqueous angiography of the children also, where we can show the aqueous outflow channels in these eyes. So we used to use ICG dye intracamerally. So we got to know that ICG stains trabecular meshwork beautifully. So now we are doing GAT in hazy corneas also with the help of ICG dye. So even in the hazy cornea, if we instill the dye, we are able to make good view of the of the trabecular meshwork, because even despite the hazy cornea, and we're able to complete the GAT surgery, which otherwise would have been difficult. So this surgery also taught me a lot of things about goniotomy that I was doing previously and helped me reform myself. That I would say that even now some people may be doing goniotomies at wrong position because the angle is featureless, and sometimes people do end up in creating cyclodialysis cleft, which gives a pseudo feeling that the IOP is lowered because of the right incision, but these eyes will eventually go into higher pressures as the cyclodialysis cleft close, and that could be one of the reasons why goniotomies don't do so well over long term, and we actually do CTT only as the first line procedure. We used to do that. So it was a learning experience, and it has been very rewarding in the sense that when we now we have sent CTT versus GAT results for as a comparative study in this cohort, and we found that though the IOP loading is almost similar in the two groups, the eyes that undergo CTT, they require more often EUAs. Sometimes we need to do bleb needlings because of the tight suture. In the first EUA, like 4 to 6 weeks, IOP may be on the borderline side. So in that stage, we also do needling, and we open the pathway. Sometimes AC is shallow, so we need to take the baby in between to form the AC. So the number of EUAs, the number of secondary interventions is almost like nil in GAT. Only first EUA is our standard protocol, when we do it at 4 to 6 weeks to remove the sutures at the corneal ports. Other than that, we don't really need to do EUAs for them. If they show high IOP, then of course we take them for secondary intervention. But the concept of AC shallowing is not there with GAT if you close your ports properly. So it has been really a rewarding experience so far.
Very good pearls actually on how to visualize, because that's the with especially if the eyes are a little bit enlarged, a little bit ophthalmic, the anatomy you cannot find it.
Yes.
You might just be imagining things and doing. So those are very good tips in finding the right place to
Yes.
do the GAT.
Yes. Thank you.
Okay, thank you. Any questions from the group? Yeah, there's some presenters who couldn't make it due to some issues getting their travel documents. Dr. Fang Zhang was kind enough to send a video, and we'll just maybe listen to his presentation, recorded presentation.
Good afternoon, esteemed colleagues. My name is Xiaobin Xie from the Eye Hospital, China Academy of Chinese Medical Sciences. Today, I am honored to present our prospective study on the efficacy of bleb needling revision for late failed trabeculectomy blebs, a critical yet understudied intervention in the era of minimally invasive glaucoma surgery. Despite trabeculectomy's irreplaceable role, only 67% of patients achieve target intraocular pressure at 1 year. The debate persists: can we salvage long-failed bleb before considering more invasive procedures? Late failed blebs often lead to recalcitrant intraocular pressure. Prior retrospective studies show mixed outcomes. 30% qualified success in Asian eyes versus 70% in Western cohorts. We hypothesize that bleb needling augment with continuous anterior chamber infusion offers viable alternative to repeat surgery or drainage devices. Our study objectives is to assess the efficacy of the technique in Chinese glaucoma patients and to identify predictors of success or failure to optimize patient selection. So this study is a single center prospective study. Enrolled 36 eyes with dysfunctional bleb after trap for over 12 months. Bleb needling was performed by a single surgeon. Post-operative injection of 5FU and daily ocular massage were recommended. The average duration from the last trap to the needling was 7 years. This table and figure shows the changes in intraocular pressure and medicines over the 24 months follow-up. Bleb needling significantly reduced intraocular pressure and medicine use. At 12 months, 36% patients achieved absolute success, 27% qualified success, and 36% failed due to requiring additional surgery. By Kronfeld's classification, post-needling, the number of flat blebs decreased from 28 to 13, and cystic diffuse functional blebs emerged 14. By anterior segment OCT, after needling, subconjunctival separation and multiple layer appears, while uniform and microcystic multiform blebs decreased. Multivariable Cox analysis reveals 3 critical predictors of failure. Age, Kronfeld grade 4 encapsulated blebs, and non-bleb area vascularity per Morpheus bleb grading system. This slide shows a 69-year-old POAG patient with flat bleb, pre-needling intraocular pressure 25 millimeters of mercury, dropped to 12 post-needling, sustaining success over 24 months. However, these 62-year-old patients with an encapsulated bleb experience failure after needling. So our finding affirm that late bleb retains functional potential. 2 key points. The first, older patients benefits more. The second, avoid encapsulated blebs and high non-bleb vascularity. This approach may avoid 36% of cases progressing to invasive glaucoma surgery. Thank you.
So that's a great presentation. Too bad Dr. Zhang couldn't be here. Who among the audience does late bleb needling? Great. So sometimes it really depends. If it's a little bit elevated, you could actually try to resuscitate those blebs. But if it's totally flat and it's a lot vascularized, it's a bit difficult.
Study is great. So because traditionally it has been taught that the needling should be done in the immediate post within 6 months of doing this trabeculectomy surgery, and ours is a referral center, so we do get referred trabeculectomies which are failing, which have been done quite long back. So we don't really go and do retrab every time. We try and open up the first site, even if we're not able to visualize the bleb or even the scleral flap. So, but as we go in with the dissecting movement of the needle, we can actually, open up more than 50%. Correct. And we do a lot of slit clamp needlings also in the OPD itself. So the pearls that she shared were really useful, that older age patients do very well compared to JOAGs, for example, because they have thick tenons and the results are not so good. And also if they are, focal ring of steel. So, and with the whitish looking conjunctiva, they really tend to do well over long term. So the additional pearl that I would advise, that after needling, we do advise massage to these patients at home. So maybe 2 or 3 times a day. So that helps aqueous to keep draining. Otherwise, they tend to fail. But if the patients are advised massage well, they do show good success, and we may not need to repeat any surgical intervention. So what is your approach like?
Yes, similar to yours. Again, AIOS is a good antifibrotic in itself. If you keep it flowing, then usually you could have those late needlings that work well. Roughly, we've reviewed our results, and it has a success rate of around 50-60%, but it's worth a try rather than going to another repeat trabeculectomy or even a glaucoma drainage device. So it saves one more procedure. So usually I prefer those blebs that it's a little bit localized, no ring of steel, no vascularization, and you know it's gonna work once you needle it and just pops up and it extends. That should be good.
Do you do congenital glaucomas also?
Yes, I do congenital.
How do you do needlings for them?
Once they fail, they fail. I don't know. What's your experience with a
We do
trabecular?
a lot of needlings and even PCG.
Okay.
So then again, the parents have to be advised. Some other
One more question, sir.
Sure. Let's complete.
Augment the needling with Tyrefu or mitomycin, or you do just bare needling itself and you don't augment it with any other antibiotic?
I augment at the very least fluorouracil FU. In those that have a lot of scarring, I might even go with mitomycin C.
we inject subconjunctival 0.1%.
Even when we are doing at the slit lamp also?
Not at the slit lamp, not at the slit lamp, but in the OR when we take the patient, so we do subconjunctival posterior bleb injection for 0.1 ml.
Okay.
Yeah, so when you do late bleb needling, what's the rate of, how long does it persist after late bleb needling? I'm talking about say after 5 years later you're doing a bleb needling. How long, if it's, you said the success rate about 50%. In a success case, how long does it prevail, roughly?
If it works quite a long time. I don't know the experience of the others, and I think with the results.
Evaluated actually, because TRAB success is also like 60% over 5 years. So how can you say that a late needling of this failing TRAB will work for 5 years? At least for 1 year or 2 year, it's giving you shelf life to decide for any future surgery. So that's a good enough. I would say it is successful if it works for 1 to 2 years also.
And more often it works better if the bleb is slightly cystic raised, but there is a ring of steel. But if it's a very flat bleb, then
No.
probably, and then you do internal needling also along with the outside needling,
Yeah.
then maybe the
So we do enter the AC every time.
every time you do. The internal revision also you do every time.
Slit lamp also, but then you have to have that fluid. You have to see the fluid. So the needle first you do subconjunctival needling, and then you have to do subscleral needling. So in a flattish bleb, we're talking more about subscleral needling. So if you address that, it's not necessary that the flat blebs cannot be resuscitated, but you have to let the. And the other point is the ostium that we create with the needle.
Can we have a
And
mic,
then
please?
It has to be. Sorry, I have the mic.
Oh.
So there are two aspects of needling. One is the subconjunctival needling. The other is the subscleral needling. So in flattish blebs, we expect more of subscleral needling, where is no aqueous flow outside at all. So what we do in these cases is we really take the needle, and when we are moving with the wind viper movement of the needle, we tend to create a larger ostium, also in PCG. So when we are entering in the intracameral space, we tend to cut with the needle for a larger ostium, so that it doesn't close again. So that's again another pearl. So that is, you have to see the needle go inside, cut it a little bigger ostium, and give mitomycin C and ask the guardians to do the massage. So other than that, then you have to take the patient for retrab if it
Yes,
doesn't work.
or something a bit more. Again, the problem, if it's flat, usually you have a thick fibrous layer that even when you try to do bleb revision, it's really quite thick, that even if you needle, if it's flat, it's more difficult. It can still be done, but even if you lift the flap and create an ostium, it's this subconjunctival space. You have primed the fibroblasts already, and there's a tendency that it will fail. But it's worth a try.
We tried oral doxycycline in our center, giving the patients which are trending into fail. So they do show good response. The bleb seems to be larger in them and tends not to fail. Although we did only 10-15 patients. It's published, yeah. So oral doxycycline can also be tried in these patients.
Okay, great. Thank you for all the tips. Any questions from the audience? Okay.
Ab interno approach much, only in cases where the iris is blocking the ostium, then we have to go inside the AC and do it. Otherwise, our to-do technique is ab externo only. So behind the bleb, you have to little be far from the bleb, and then with the wind wiper movement, you first try and break the entire subconjunctival area. So let it be a larger area, not exactly at the point of the needle entry. So little be a larger area for diffuser, filtration later on. And after you have done the subconjunctival fibrosis cutting, then you enter into the subscleral space and try to do it throughout the scleral dimensions. And then you enter in the intracameral space
So
with
you
the needle.
don't excise the conjunctiva.
Sorry?
You don't.
No.
Oh,
It's to
okay.
the needle entry.
Oh, okay.
Yeah, you can do it.
Oh,
Yeah.
okay.
Yeah, that's a very good point. Make sure first you do the gonioscopy to make sure that there's no iris blocking it, because you might be needling and everything and it's not going up. It's because you have an iris stuck there.
No, usually the pupils are not round, so we even without gonioscopy we can make out that the pupil may be stuck. So this happens usually after massage. Patients come back.
Correct.
With when they're doing massage at home, sometimes they may be more more aggressive and the iris sometimes. So we first try pilocarpine in these eyes for an hour. Every 10 minutes, the patient instills pilocarpine drops, and then if it doesn't happen, we can do it on the slit lamp also. So I have an air filter with me in the OPD setup. So that air filter, it gives us sterile air. So with the needle, I put that air filter in the 2 ml syringe. I put some air in my needle. And when I pull the iris back, and if the AC is shadowing, I just put some air through that. So it gives you, it happens rarely, but you can always do it in the OPD.
Okay. Yeah. I presume the pilocarpine are for older patients, not for your congenital glaucoma patients. Okay. The older ones. Okay.
For that, we have to, of course, take them to the OT.
Okay, great. Any other questions or tips that you want to share? Yes.
How does one take care of subconjunctival bleed and potential hyphema?
Okay.
How would one take care of
So
subconjunctival
prevent
bleed?
it first. Usually I
Yes.
do I apply a vasoconstrictor before I needle. You may also want to choose to use lidocaine with epinephrine. There is some that's already a mixed. The only issue there, sometimes it dilates the pupil if you take a bit too long.
Okay, so you mean topical?
Topical first, vasoconstrictor,
Yeah,
just
in
to decrease the
adults.
chance.
Okay, all right. And in children, it would be subconjunctival injection of a vasoconstrictor or a drop. What
Yeah.
would it be?
I rarely do needling in children once they fail any.
Right. So how do you prevent?
If they are really congested, we don't do them on slit lamp. Then we take them to the OT, and using AIOS2025 we do them then.
Right.
But for clear conjunctivas and for older patients, you can always do. It doesn't really bleed in those eyes. If you're feeling that it is trying to bleed and they are the sensors not controlled, then doing them under good block where it is controlled
Right.
in the OT is always advised.
Or use a xylocaine with adrenaline.
Yes, correct.
Yeah. Okay. Thank you.
Brimonidine helps in
Yeah, it also helps.
eyes,
Yes.
ladies. The
Thank
topical
you.
brimonidine
Thank you.
Anything else? Anyone in the audience who wants to share their experience? Or any questions for that matter? Yeah. Oh, he told me he was going to be late. He's a very busy man. Okay. Any other presenters who arrived? None. Okay. So it's too bad. There were a lot of interesting papers that's supposed to be presented today, but I guess there's none. They couldn't make it for one reason or another. Any, but if you want to make use of this time for any tips or any questions, and the important thing about these meetings is getting different perspectives in management. I think we have a good group here. If you have any questions with regards to management in the audience. So with congenital glaucoma, even with really ophthalmic eyes like 14 millimeter corneas, you would still do?
So it seemed, although what we did was less than 14 millimeters,
Can we have mic? Yeah.
The age criteria is, I think, one of the most important, and sometimes we do miss, ocular anomalies. For example, we may think that the patient is primary congenital glaucoma, but he turns out to be something like congenital ectropion UVA, or something like ARS, Axenfeld-Rieger syndrome, which is subtle at that time, and iris hypoplasia develops later on as the progressive iris atrophy occurs. So these are poor case selections. So GAT will not work. And half of the times you will end up not be able to cannulate the Schlemm's canal also, because it is less formed. But for primary congenital glaucomas, if they are less than 1 year, and despite being severely buophthalmic eyes, the surgery does do well.
Okay. Well, if it fails, what's your next step?
Trabeculectomy.
If that fails, what's next?
So we do tend to do needlings 2 or 3 times in these
Okay.
babies before we do a retrab. And if a retrab also fails, then the last option is glaucoma drainage device.
Okay.
And I preferred glaucoma drainage device as AGV as of now. So have you tried ACP?
ECP for kids?
ACP, the Ahmed Clear Path.
Ah, yes, I've tried it.
You
It's
have tried.
available. The great thing about it, again, it's just a matter of what you want, a non-valve or a valve.
Yeah.
For the valve, sometimes with kids, they cry, they rub, so it's a
Yes.
little bit, you could get high flat chambers and hypotony.
Yes.
I tend to do a non-valve, whether it's a barbell or the Ahmed Clear Path or even the Paul implant, because you have a very small tube. I try to ligate it and make sure that there's going to be resistance. So I with an absorbable suture. So once after, as long as I could control it, if
So
the
in congenital
pressures,
glaucoma also? With congenital glaucoma also, you do a non-valved device first?
yes,
Okay, so how do you titrate when to take out the ripcord? You put ripcord also?
I put the ripcord. But how if it usually in congenital glaucoma they don't work so well. Their pressure's uncontrolled. You cannot control them medically. So I do a bridge trabeculectomy.
Okay, okay,
So
right.
So
Right.
so by the time
It's a lengthy
without
procedure.
mitomycin C, then it's going to fail in a month.
Okay.
Then you're all set.
Okay, yeah.
The reason being, sometimes we're all a product of our last bad case. Once I put an AMID, then the chamber was flat and wouldn't.
Okay, so everybody has different experiences.
That's what's
I
great about
did
these
ACP in
meetings.
4-5 eyes, not in congenital glaucoma, in adult eyes, and I had a higher than normal frequency of the tube exposure. You wanna
Tube
say something?
exposure.
No, I haven't tried a ACP, but I am doing. I've done a few ADIs, the smaller ones.
So the 250
But not in
ADIs.
the children's, actually. I had operated children's with AGV, and they actually did fine. But what I have learned from you is that you had a very bad experience with that.
Yeah. Again, that's anecdotal. But if I do a non-valve with a bridge trabeculectomy, in other words, do a trabeculectomy beside it, it seems to control it in the first month. Then you're all set after.
So, what would you do in a slightly older? That patient, I'm really actually managing this patient at the moment. I had a pediatric glaucoma, did a trab, failed, did a AGV, failed. Now 18-year-olds. I'm planning to do a repeat AGV. What do you think?
For those, sometimes I even do an exchange.
Exchange? No. Ah. This has
Yeah.
been done some time back, about 7 years back. Yeah. Now this AGV was done some time back, about 5-6 years back. Silver sir.
Yeah. Sometimes it works, sometimes it doesn't. It's worth trying because again, you don't have a chance of hypotony with that. It just drops down to 8 to 10 in the first few minutes, but sometimes it creeps up. Batting average around 50%.
If you happen to insert a second AGV, where would you insert?
If the AGV fails, if I need to
No,
replace it,
Yeah, second AGV. If you're planning to insert a second one,
I would go with a non-valve already, do an exchange, take
Yeah.
out the AGV, put in a non-valve like an ADI Barvelt or an AMED clear path.
So what would be the location?
I would remove it.
Are you going to remove the first one?
Yeah, then do an exchange.
Okay.
If it's really fibrotic, it's a little bit tough. The easier one would just to place inferiorly. If the patient isn't that young, because again, you don't want an infection. So it's usually inferior nasal.
So what is your experience with the cystectomy to these encapsulated blebs of AGV?
If you get the chance to open up a capsule of an AMED, it's actually thicker than the sclera, the ones that have a hypertensive phase. So it's really thick. If you compare it to a capsule of an AADI or barbell, it's very nice. It's almost similar to that with an episcleral band. It's thin, but with the AGV, it's really thick. It's very thick. So.
Do we augment these cystectomies with mitomycin? Few people do.
Yeah, some would. There's no evidence. Although if you want to prevent a hypertensive phase for AMED glaucoma device implantation, one thing that has worked for me is aggressive aqueous suppression in the early. And if you look at the study of Ying Han of UCSF, before I wasn't a believer of using mitomycin C, but she has a protocol wherein she injects mitomycin immediate post-op, 1 week, and 4 weeks. She did an RCT. It seems to have a lower chance of hypertensive phase. I've started my own series. It's too early to tell, but it seems promising.
But the aqueous suppression theory is actually working well.
Yes, because again, the issue there is the early exposure of the capsule to two things, either inflammatory mediators or just the pressure effect. So if you decrease the if you decrease the production of aqueous, then you have less pressure, and then you also have less inflammatory mediators getting exposed and thus thicker. Any other questions? So it became like this presentation became like a sharing of, which is good actually. Anything else? Anyone in the audience have questions or something to share? No more. Okay, I think we should close the session if there's no other questions. If you have any clarifications, feel free to approach me. Okay. Thank you for attending.